Welcome. I'm here with Michael Greenwood. Michael, we're going to be talking about an interesting subject, a lovely talk that you gave on advanced endothelial keratoplasty, Pearl's technique. But let me start out sort of more basically. So you're talking about DMEC. What I'm interested in, I mean, obviously you're an advocate of it. I hope that you wouldn't be doing surgery that you don't advocate. What have been the barriers to adoption, and why is it that overcoming those barriers is even worth our time?
Yeah, a great question. And I think one of the biggest barriers is that the surgical technique is a little bit different than what people are used to with previous endothelial keratoplasty. So with DSEK, you put the tissue inside the eye, and it's generally easy to manipulate and get it in position. And the aftercare is basically watching the corneal heal. With the DMEC, you're doing all of your work outside of the eye to unfold a graft to get it in position inside the eye. And so there's a little bit of art to it, but that's why I really enjoy the procedures. There's a little bit of technique and flow to it. It's a very elegant procedure, but there is a sort of a steeper learning curve for people that had done endothelial keratoplasty in a different manner. When I went through my training, DMEC was coming of age, and so that's kind of where we learned first, and so that's just a natural step up for it. So basically anybody can learn it, you just have to put in the time to learn some of the subtleties with the techniques.
I'm interested in what the payoff is here. So the graft tissue for DSEK, when you were learning DMEC, is not the sort of graft tissue that we are using now. What's the comparison like in outcome and recovery for patients with the newer, super thin DSEK grafts compared to DMEC?
Yeah, I think there's three advantages that DMEC has over other endothelial keratoplasties, and one is the speed of recovery. The second is visual acuity outcomes, and the third is safety. And so with the recovery, a lot of these patients are doing quite well a couple weeks after surgery, where they're at their sort of final vision outcome. These grafts clear extremely quickly, and they get great vision, sometimes as early as week 1, but usually around weeks 2 or 3. The visual acuity outcomes, we've published data on this, and there's been a lot of other publications, but on average, patients are getting 20/25 or better with DMEC, which is something that you can't really achieve as easily with the DSEK. And then the safety is the biggest one for me, and that's one of the biggest reasons why I do it, is patients that have an endothelial keratoplasty with the DMEC, their risk of rejection is less than 1%, or around that range, which the other grafts, you just can't get that safe. And so those are the reasons why I really, really love it, and I think it's worth surgeons learning how to do, and it's obviously doing great benefit for your patients.
Now, I'm going to ask sort of two questions at the same time, very similar questions. One of them is, if I have a DMEC practice, if I have a DSEK practice that I'm very comfortable with, what are some ideas, some pearls, some thoughts that you can give me that will make my transition to getting sort of my toe in the water with DMEC easier, number one? And number two, what is the best way for me to learn it?
Yep, and I think they go hand in hand. And one of the early concerns is preparing the graft tissue. And at the early stages, it was very difficult to prepare the graft tissue. Surgeons had to do it themselves and kind of start from scratch. But the eye banks have been so great at learning these techniques so that when we order it now, it becomes preloaded. And so it's almost as simple as ordering something off Amazon. It just shows up, which is not to downplay the work that the eye bank does. I mean, their work is tremendous, but it makes it very easy on our end to get started with it. The other thing that's great is, kind of what we're doing now, live video, is that with ophthalmology, we can learn everything sort of online with iTube, YouTube, whatever video platform you want. So you can watch surgeons who have instructional videos kind of get you started and show you how to understand it. It's your own education course. But there's wet labs you can do. You can go visit friends. You can visit your partners. You can come visit us in wonderful North Dakota where it's blizzarding right now, and learn how to do these techniques because we have the capability to record everything. You can learn it very quickly that way. But the wet labs are fantastic. They're at all the meetings. And so just like anything, it's doing a little bit of education on the front end, but now you've got great videos to learn from, and then getting your hands wet either with someone else or in a wet lab.
What is perioperative care like, and is it any different from the DSEK?
great question, and that's another thing that people have to learn is our rebubble rates with DMEC are higher than they are with DSEC. DSEC, somewhere around 5% or so. But with DMEC, it's somewhere between 10 and 20%, depending on what publication you do and how you practice. And so when a DMEC graft isn't perfect or it's a little bit slower healing, it's usually sticking the way you want it to, but not 100%. And so you just have to put a little bit more air in to get that tissue that's not sticking to re-stick. And so, but you can do that in the clinic. And so you can do it at the slit lamp where you just put a little bit more air in, you have the patient lay back down, and so that bubble can act like 1,000 tiny little hands to push that graft back into place. And within 3, 4, 5 days, that tissue is cleared and the recovery is there. And so there is a little bit of a learning curve with the surgical technique, but a little bit of learning curve if you don't have 100% graft clearing at your visit, post-op visits. And usually that's at 1 week, and that's all you have to do with it. But the aftercare is very similar. They're on a steroid for a little bit of time, but we can get them off the steroid after a year and still have great safety with it.
Michael, this is great stuff. Ultimately, what we want is good outcomes for our patients, and it's not, doing a procedure that gives better outcomes is not always the obvious choice, because if our complication rate during that steep learning curve is higher, maybe for that period, it's may not give better outcomes. Or at least it gives us the anxiety that it might not. I want to thank you very much for sort of emphasizing this topic for us. Obviously, this conversation is not one that I'm going to come into not knowing how to do DMEC and leaving this conversation knowing how to do it. But you bring up some very, very relevant points and may drive interest in following this technique through. I want to thank you very much for the generosity of the time that you've shown with us, and I want to thank you, our live viewers and our viewers who are not live, for joining us for this video.
Thank you.